I like to introduce two friends of us rather than I think I like to introduce them like two faculty members of Pallium. Dr. Rajam. Dr. Rajam is a pulmonologist and a palliative care consultant. She works with Bhatia and Hinduja Hospitals, Mumbai. She is trained in palliative care and she has done her diploma in palliative medicine, and she's also trained from Pallium India. She's been working in the field of palliative care and pulmonology since then, and has been faculty for many on-site online training programs with Pallium for the last few years now. Welcome, Rajam. And we have one more faculty for today's session, another pulmonologist and a trained palliative care doctor, Dr. Rajani Surendar Bhat. Dr. Rajani works at Sparsh Hospital, Bangalore. She's also trained in palliative care. She has done her one-year fellowship from IPM Kerala. And she is also practicing palliative care and pulmonology for many years and a faculty with us for many of training programs. Welcome, Rajni. So both of them will be talking about palliative care and respiratory illnesses. And Rajam and Rajni, these are a group of doctors who have already trained from us in various training programs, and this is a part of their refresher course. Welcome you both for the session, and over to you.
So I think Rajni is going to do the initial starting, but I can't. Can you see her online? I've just sent her a message. So we are going to split the talk in such a way that Rajni gives a general overview of there she is, of the need and the current status of the respiratory burden in India, of the various conditions that we are going through. And I'll go through what we see from the palliative care aspects. Of course, if Rajni also will chip in at that stage, we probably have a case discussion, which Rajni is going to introduce, and then we'll see. So both of us will play complement to each other and hopefully be able to give you an interesting interactive session. So please stop us anytime, put the comments on the chat or questions, and we can stop at that time and clarify the doubts. So over to you.
Hi, good evening. Apologies. I got a little late joining on as I got stuck at work. I'm going to ask permission to share screen. It's wonderful to see so many of you who are enrolled in the refresher course. Is my screen visible to everyone? Yes, thank you. So as Dr. Rajam has mentioned that we'll be looking at what is the problem statement in terms of the need for palliative care in patients with chronic respiratory disease, understanding what the burden of these symptoms is, the fact that there's still a long way to go before we start meeting the needs of the patients in our communities, and what are the issues that we need to address with that. And then we'll go on to discussing the specifics of symptom management that we come across. Now, as palliative care practitioners, you are all aware of the fact that palliative care begins from the time of diagnosis of an illness and goes on until beyond the demise of a patient, until bereavement. The fact is that for the longest time, even the pulmonology professional bodies or the respiratory professional bodies have been trying to impress on the minds of practitioners across the world that palliative care is not something that is initiated after a certain time when curative and restorative care is no longer having the desired effect on a patient, but should be initiated right from the time of diagnosis. And the primary intention or focus of treatment may shift at various times depending on the trajectory of the illness. So this is, what is this? And this was there in an American Thoracic Society statement as long ago as 2008. So we're 15 years past that. And I wish I could say that the practice reflected that after 15 years of an official statement that we all did practice palliative medicine right from the time of diagnosis, but there's a lot of catching up we yet have to do. When we think of how do patients with chronic respiratory disease fare, when you think of the possibilities of how diseases progress, eventually leading to death, these are what we call the 4 roads to death, where sometimes you have a sudden death due to an accident, to a massive CVA, a massive MI, but that's about 7%, less than 8% definitely of people across the world. A smaller number, maybe about 16% or so, will have a terminal illness that is diagnosed, which is rapidly progressing. And from the time of diagnosis to the time of death, it might be 6 to 9 months, and the end comes quite quickly. The rest of the population in the world will have some chronic disease that is diagnosed, or will have old age and frailty. So there's this gradual progression that we see where there is a known chronic disease. So in the patients, with our pulmonary patients, it's something like COPD or interstitial lung disease or pulmonary hypertension or the sequelae of a chronic infectious disease. And what they have is gradually progressive organ failure, where there's dips in their health every time there's an exacerbation, they get weaker and weaker. So clearly, in almost 75% of the world's population, we know that the end is coming for years. Yet we are not addressing it adequately. Specifically, when we look at pulmonary patients, from the time they are diagnosed, let us assume that there is always a delay in diagnosis of chronic diseases. We all know that people who are diabetic or who have heart disease have all had some prodrome of the illness where they had some symptoms but were not fully diagnosed. The same applies to pulmonology as well. Very often patients with interstitial lung disease come to us having gone to doctors for 3 years, 4 years, being told it's asthma or something else until they realize it's a progressive disease. And there's already been some fair degree of loss of lung function. So in those situations, what happens is, if it is the kind of chronic respiratory disease which has a poorer prognosis, right from the time they find out their diagnosis to the time of death, maybe a short time, or there might be an exacerbation, but there's definitely a loss of some amount of what would have been their life projection if they did not have that chronic respiratory disease. So the pathways and the trajectories of the disease, we can clearly say in all patients with chronic respiratory disease, is something that from the time a diagnosis is made, we know that it is going to cause a hastening of death in some shape or form, or an increasing burden of symptoms. So it's important that we address this with a palliative care approach right from the time of diagnosis. When we look at the idea of palliative care for respiratory diseases, when I finished my fellowship in pulmonary and critical care medicine, at that time, if we looked at the publications about respiratory symptoms or palliative care for respiratory diseases, in an entire textbook of palliative medicine, there was only one like out of a 1,000-page textbook, there were less than 30 pages or something that were devoted to dyspnea and other symptoms. In the following decade, from 2000, so and the same is true for research publications. When you look at the research publications on breathlessness, on respiratory conditions, they were a fraction until 2010 compared to what has happened in the last 2 decades. So there's definitely been a greater advance in our understanding of what are the burden symptoms, the myriad symptoms that patients with chronic respiratory disease have, as well as the amount of research and work that has gone into it. Our understanding of pathways about breathlessness, about cough has improved. And therefore, we are now better equipped to be able to offer better palliative medicine for patients with respiratory diseases. Now, keeping that in mind, that there's been a growth in the literature, growth in the understanding of disease and treatment modalities that are available, has that really impacted patients' life? When we look at the burden of chronic respiratory diseases, India has a disproportionately large number of patients with chronic respiratory illnesses. We are home to 1/6 of the world's population, but we are home to 1/3 of the world's total number of people living with chronic respiratory disease who have significant disability due to respiratory disease. This is a disease. This is a photograph that I have taken from this, a portal called Humans of Mumbai, where they share stories which are of human interest. And to me, this sort of depicts the burden of respiratory diseases that our patients in our communities face. You have a young man who is who's using a hand cart to pull a burden of large number of bales that are put on it. An older man is trying to walk alongside, seems to be dejected, seems to be tired and exhausted. To me, that is the patient and that is the caregiver, the young man, the caregiver, the older man, the patient. And that burden that they are carrying is the sum total of all their symptoms and all their suffering, be it physical, emotional, financial, spiritual, all of those. So clearly, this burden, this disproportionate burden that we see across India is something that needs to be addressed. Therefore, it's important that we examine this aspect of palliative medicine, palliative pulmonology, relief of respiratory symptoms with a lot more intensity. COPD is the third leading cause of death in the world. The 5-year survival is more than 70%. Now, what does that mean? It's very different from cancer and some other illnesses where the 5-year survival is much less. What it means is that patient lives longer with a lot of symptoms. We have the largest burden of tuberculosis in the world as well. The deaths due to tuberculosis in India are appalling. During COVID times, if many of you would have noticed that there were websites and government portals which used to carry the daily death toll due to COVID. And we were all alarmed and shocked when we would see 1,000 people dying every day because of COVID-19. 1,000 people and more die every day in India because of tuberculosis. The death toll as sequelae of tuberculosis or directly due to tuberculosis is anywhere between 3 to 5 lakhs per year in India. So if you think about it, more than 1,000 people per day are dying because of tuberculosis. Globally, the deaths due to TB are falling. So even this 1,000 per day that is happening, the number is falling in India. But what happens is that they continue to live. We call it a success of treatment, but the patient has a lot of chronic long-term symptoms and their quality of life is diminished. Their overall longevity is diminished. So this is a very large problem, definitely in our country. What about countries which have robust national healthcare systems, public health systems? So these are some data from Swedish studies, Danish studies, which have robust national healthcare systems as well as palliative medicine services. So when they took a comparison of COPD patients and cancer patients, both of who required oxygen at the end of their life, they found that the symptom burden was much higher in the patients with COPD, whether we're talking of breathlessness, anxiety, pain, nausea. The patients who had cancer, who were on oxygen, had greater access to opioids, had greater access to palliative medicine, had greater access to prescription drugs to help relieve any and all of their symptoms, whether it was pain, whether it was breathlessness, nausea, or anxiety. Somehow the same compassion and the same care was not extended to patients with COPD who were on oxygen. In all advanced pulmonary diseases, this is the scenario. In patients with advanced COPD who are dependent on oxygen, who've had multiple hospitalizations, death is expected in that final 1 year. Good clinicians know that repeated hospitalizations, an ICU hospitalization, an intubation and ventilation means that the patient's likelihood of surviving more than 1 year is low. However, referrals to palliative care were not so many. End-of-life discussions did not take place in these patients. they were more likely to die in the hospital. For patients with COPD, for patients with ILD, for patients with pulmonary hypertension. And if you speak to the doctors who are taking care of these patients with advanced COPD, pulmonary hypertension, or ILD, they are comfortable in all the elaborate drugs that are necessary to treat interstitial lung disease or pulmonary hypertension. But they're not as well versed in how do we use opioids, benzodiazepines, and pain management, anxiety medications, all of this for relief of symptoms in patients with chronic respiratory disease. So why is this that we are discriminating in some way in patients with chronic respiratory disease who suffer with a high symptom burden for more than 5 to 7 years, at times 8, 10 years, high symptom burden, poor quality of life, significant disability, and decrease in health-related quality of life. So there's so many different aspects that comes into palliative care and respiratory symptoms, right? Look at the large variety of patients who would be needing palliative care for respiratory issues. You could have the need, there is a need for palliative care in respiratory diseases or respiratory symptoms. So if I have a patient with COPD who has breathlessness, that's a respiratory symptom in a patient with chronic respiratory disease. My patient with COPD could also have pain, could also have constipation, could also have sleep disturbance. So palliating the non-respiratory symptoms and advanced respiratory disease is also a huge felt need of that population. And respiratory symptoms are there in all end organ failures. If you look at chronic kidney disease, these patients have breathlessness. End-stage heart failure, these patients have breathlessness. End-stage liver failure, these patients have breathlessness. End-stage neurological disease, Parkinson's, multiple system atrophy, multiple sclerosis, post-stroke patients, traumatic brain injuries with aspiration, all of these would have respiratory symptoms as well. And all end-of-life discussions will involve management of respiratory symptoms. So what is this big, giant, complex respiratory symptom complex that we are dealing with? There is breathlessness. There is low oxygen levels, hypoxia, which is measured. So there is one thing which is the symptom of breathlessness. There is another thing which is the objective measure of low oxygen saturations. There is cough. Cough is the second or third most common complaint that people across the world seek medical attention for. Seems like a very innocuous thing. All of us have experienced a cough sometime or the other. But imagine if that cough is incessant, morning to night, exhausting you and distressing you to a level where when you cough, your ribs hurt. There are fractures that are happening in your ribs. Imagine if you cough and there is compression fracture of your vertebrae. Imagine if you cough and there is stress, incontinence, and loss of dignity with incontinence. Imagine that you are not able to speak one full sentence without coughing. And if you are a teacher or if you're a person whose vocation, whose livelihood depends on talking and speaking, and that is not possible for you. So this very simple symptom can be something which completely takes away the quality of life of the patient. Patients can have a large amount of secretions. We have patients with bronchiectasis the cause of the bronchiectasis could be some kind of inherited or genetic disorder, familial disorder, or it could be post-infectious, like with tuberculosis. And these secretions are copious secretions. Sometimes patients produce up to 1 liter of mucopurulent sputum when they have bronchiectasis. Sometimes they suffer from very severe halitosis because of these secretions, because of the colonization of microbes in these secretions that are there in their chest. And that causes social embarrassment, not being able to go and attend school or college or work, having to lose your job. I had a patient who was a chef at a restaurant, and he had terrible bronchiectasis following fibrocavitary tuberculosis. And subsequently, even though the tuberculosis was something that was successfully treated, so to speak, he was left with bronchiectasis, Pseudomonas colonization, and lost his job because nobody is willing to employ a chef who has bad breath because they think he is unhygienic. Hemoptysis is such a distressing symptom. When you're coughing up and blood comes out, a very distressing symptom, and also something which causes severe panic and anxiety. One coughs, a small amount of blood which would not be so consequential in another part of the body, 150 ml of blood is called massive hemoptysis, because that can lead to complete respiratory failure. Patients have pleural effusions. Sometimes when they have any kind of malignancy, they can have pleural effusions related to other end organ failures like heart failure or kidney failure or liver failure. Patients can develop airway obstruction. Sometimes it's because of a post-intubation tracheal stenosis or a granulomatous kind of inflammation after having an endotracheal intubation. Sometimes it can be TB bronchostenosis. So all of these things cause severe symptoms of breathlessness, panic, stridor. All of those are possible. And then, as we spoke, there are non-respiratory symptoms in chronic respiratory disease. There are studies which show that as much as 40% of patients with COPD have some form of pain or the other, because they're using their accessory muscles, because they're not able to lie down comfortably. So they develop pain in various parts of their body. We spoke about cough and how cough can cause rib pain, back pain. Patients experience nausea, constipation. Many of them have comorbidities, cor pulmonale, congestive heart failure, have to be on fluid restriction, and could develop constipation also. Anorexia, as the disease progresses, they develop anorexia and muscle wasting because of their breathlessness, because of their cough and anxiety. They sometimes have significant sleep disturbances. They may also have comorbidities like obstructive sleep apnea or obesity, hypoventilation. They may have to use devices, oxygen and CPAP or BiPAP machines. The devices and their sound also interrupts in their sleep. They may have nocturia, which means they have to get up many times to go to the bathroom, and that will cause sleep disturbance. They may have dry mouth because breathlessness gives them dry mouth. They're using diuretics to keep their volume down. Over time, they may have experienced many episodes of hospitalization with breathlessness, and that leads to the sense of panic. Every time their breathlessness increases, they're worried. Oh my God, will this get better on its own? Or will I need to go to the hospital? How much expense is this going to be? How many days am I going to be hospitalized? So there are these kind of very scary cycles of thinking that they get into. They become lonely and isolated, especially when they get into requiring oxygen. Portable oxygen is expensive. So sometimes patients then end up becoming housebound because of their chronic respiratory disease. Over time, their relationship with their caregiver may change. What was initially a loving relationship in a family becomes one purely of, have you taken your medicines on time? Have you taken your nebulization? Have you done your breathing exercises? Do you need help to go to the bathroom? I have time now. I can help you now. Otherwise, I have to go finish my work. I have a meeting online. So this becomes this complete feeling of I am a burden and guilt as well. And of course, there is depression with all of this. So there's clearly a lot of symptoms that one has to be aware of and proactively look out for to see how you can help the patient and their family find the solution for this. So, very often when the patients come to us, they come not knowing that there might possibly be small fixes for many of all these symptoms and troubles that they face, coping with this burden of their chronic illness. Because what ends up happening is we end up only measuring the objective parameters of saturation, a peak flow, or echo readings, or an X-ray or a CT scan, and say, okay, you are doing well, and that is fine. Or we were continuing the same medicines, whether you're doing well or not, there is no change in medication. So are we really listening to how is this disease impacting the patient's life and helping them find solutions? So the palliative medicine approach to it would be to see not just what is the matter with the patient, but what matters to them, and finding ways of alleviating any kind of health-related suffering that they are experiencing. I'd like to spend a minute on breathlessness over here. Our understanding of breathlessness has been rather limited. Most of us understand pain reasonably well because we've all had some experience or the other with pain. Even breathlessness, we've had some experiences with. If you try to think of a moment when you were late for a lecture or late to catch a train or a bus, and you run up the stairs to try and make it on time. And when you reach the top of the stairs, you are working to get a breath in. You're in, your lungs are trying to get as much air as you can, and you're panting, your heart is racing, you might be sweating profusely, you might be a little tremulous. That sensation goes away quite quickly. So I'd like us to take a moment to just do a small little exercise. So I want you to sit comfortably and make sure that you're not restricted in your position. And as you are sitting, keep your hands comfortably on your legs, whether you're sitting with your legs folded or your feet flat on the ground. Just breathe along with me and watch my hand going up and down. Okay, so I want you to, as I raise my hand up, take a deep breath in all the way up to the top of your lungs, and then breathe all the way out. Empty out your lungs completely. Take a breath all the way up to the top and exhale all the way out. Now take a breath all the way up to the top, fill your lungs up with air and hold it for a second. Breathe only 1/3 out. Breathe all the way up to the top. Breathe only 1/3 out. Breathe only all the way up to the top. Breathe 1/3 out. Breathe all the way up to the top. Breathe 1/3 out. Breathe all the way up to the top. Breathe 1/3 out. Breathe all the way up to the top. And exhale. And breathe comfortably. Just normal pace. It's fine. Now one more exercise. Deep breath all the way up to the top. And bring it all the way down. All the way up to the top. And all the way down. Now only 1/3 up and out. 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 And you can breathe normally. Now, let's take a moment to think of what we experienced while we did this breathing in different patterns. Our normal breathing is somewhere in the middle here. We're almost unconscious of it. It happens spontaneously. Don't give a thought to it. At that point, when I asked you to breathe all the way up to your top and only do 1/3 up over here, that is your patient with COPD emphysema who's hyperinflated and can only breathe at the top of their lungs. They breathe a little shallow. They're always feeling like there is no more room to get more air in. And it's uncomfortable. And this was us sitting at rest. Now imagine that person having to run for a bus. Imagine that person having to get up and walk to the bathroom and hoping to make it before they have an accident and end up wetting themselves. That one which we said is all the way down to the bottom and breathing just 1/3 in and out, right at the bottom of your lung capacity. That is your interstitial lung disease, restrictive lung disease patient. Again, shallow, panting, can't get enough air in. The other one had no room to get more air in. This one can't get more air in. Again, uncomfortable while we were just sitting. Imagine walking and doing your daily activities. Imagine this being a young mother with 2 active children whom she's trying to take care of. And now having to be on oxygen, not able to do any of the things. What ends up happening when we are breathless? We have a threat to our survival. When suddenly at that time, you're already so shallow and out of breath, and then suddenly it gets a little worse, this triggers panic in us. So just like chronic pain, we know that when somebody has acute pain versus chronic pain, the entire way we respond, our brain responds to chronic pain is different. In the same way, when a patient has chronic breathlessness, it changes the way they think, it changes the way they respond, and we are now realizing that just like chronic pain has many downstream effects, and in terms of the affect, in terms of the way we process a lot of things in our brain, the same thing happens with dyspnea as well. So what are all the things that can go wrong? We notice that there are changes in cognition, your attention, your concentration, the way your thoughts race ahead to the worst possible outcome. All of that happens. There's also changes that are happening in our physiology. There are vicious cycles that set into place because of the breathlessness. One is not able to exercise. There may be weight gain. The weight gain causes further reduction in lung function. There's deconditioning. There are also side effects of medications that people have to take. And the emotional impact of all of this. For very often for patients who have been tobacco users in the past, there is a huge element of guilt that I brought this on myself. So just like we understand the concept of total pain, we could apply that principle to the impact of these respiratory symptoms on our life. And we're going to discuss further on how this is to be addressed when Dr. Rajam takes it up. What is the utility of palliative medicine in all of these scenarios? So for the longest time, one did not have a clear understanding of the real benefits of a breathlessness support service and a palliative pulmonology approach to patients with chronic respiratory disease. And though this is a small study, it's a very important study which showed us that an integrated palliative and respiratory care service for patients who have chronic breathlessness, who are dependent on oxygen, for those patients who were given the option of a breathlessness support service and access to palliative care services, there was a survival benefit that was noted. Reduced utilization of emergency services and reduced exacerbations and worsenings that happened in these patients. Now, if this was a drug, if this was a medication and you said there was a survival benefit and reduced hospitalization, it would have been used by everybody across the world. But this is a more simpler thing actually to do, but a little labor intensive. So it requires a different kind of systems to be set up. And as palliative medicine practitioners, we are uniquely positioned to ensure that this kind of service is available to our patients in order to address the entire overall impact of chronic respiratory disease on our patients. So when we look at it from the point of view of health-related quality of life, in terms of not just the disease, but what matters to the patient. So how does this breathlessness affect my life? How can I impact that patient's quality of life, even though they have to live with the disease? So you may have breathlessness, but can you help the patient in mastery of breathlessness? Can you help them in improving their exercise tolerance so that they can reach certain personal and professional goals? So if you look at it from point of view of living with the disease, yet trying to find out how to gain mastery over symptoms and be more in charge of, so, having control of the disease rather than having the disease control you. There's a huge stress that caregivers of patients with chronic respiratory disease go through. You'll find very often that patients and caregivers in interstitial lung disease groups and pulmonary hypertension groups are far more informed than internal medicine doctors and some pulmonologists also on the latest medications and trials and treatment options available, because they learn to study all these things up. There is a huge financial burden on patients. All medications for chronic respiratory diseases are quite expensive for a large part of our population. One more thing that happens is the caregiver gets focused on having to learn all these devices, nebulizations or oxygen or BiPAP machines. They are constantly stressed out about this. And there is sometimes not very clear communication between patient and caregiver in terms of quality of life, right? So how is the dyspnea impacting the patient? How is it impacting the caregiver? These are dynamics that we sometimes have to explore. Caregivers also go through stress and burnout because of loss of mobility. They can't leave the homes of the patient very often. Very often they will change their jobs to make sure that they can constantly be around the patient. But as I said, they are better at recognizing crisis than the treating doctor at times. So as long as we are able to support them, they are the greatest ally in being able to take care of the patient well. Of course, it means that we should make sure that we are also providing them with all of the support, checking in on them to make sure caregivers are taking care of their own life and their own health as well. And when the time comes, because these are people who, journey for a long time with patients with chronic respiratory disease, they need appropriate bereavement counseling to reassure them that they've done everything possible to ensure a good quality of life for their loved one. When we are assessing a patient with chronic respiratory disease, it's therefore very important that we go about it keeping all of these things in mind about what is the disease entity, what are the physical signs, and therefore how can we compare it each time they come for a visit, and do a thorough examination. Because very often we tend to close our eyes to like breathlessness must be because of the same thing. It's the one diagnosis. No, they develop new comorbidities. A patient with COPD and ILD will develop some amount of right heart failure. So looking at trying to treat whatever are the treatable traits. Sometimes patients will develop something like a slow GI blood loss, and anemia may be there contributing to the breathlessness. So making sure that each time we keep in mind open to anything else that could be correctable that is contributing to their breathlessness is very important. And how do we really measure success in this? It is by asking the right question. That, it is not every time the patient comes, sometimes for these regular follow-ups, it's not what is the matter with you? Are you breathless? Are you not? But what's going on? What is important in your life right now? How are we doing in helping you achieve that you want to do in your life? So going a little bit beyond the pure physical, to helping the patient get their quality of life and reduce their health-related suffering from chronic respiratory disease. That is our objective. And with that, I hand over to Dr. Rajam.
Thank you, Rajni. We should stop sharing somewhere.
I've done stop share.
Yeah. So what I would like to start off, I know Rajni has been nice and detailed about what we should do. I'm going to start with, therefore, with chronic breathlessness. But before I start, is there something that you all would like to ask Rajni? Because I think it's best to sort it when she's here and when she's just finished talking. So is there anything you would like to ask Rajni or share with us about your experiences? And also, before I start, I would really like to know, if how many of you are actually looking after patients with, not respiratory condition. I mean, I know most cancer patients also will be breathless, but I'm saying looking after patients with non-malignant palliative care needs. And what are your obstacles or issues that you all see on a daily basis, or often that somehow stumbles you or kind of zaps you? So let us know, and I'll give you 2 minutes to think of something to ask to Rajni. Otherwise, I'll proceed and share my screen. Anybody wants to ask a question? There is a question for you. Clinicians are reluctant to use morphine for breathlessness.
Yes, indeed. And I think that is exactly what Dr. Rajam is going to address. I know that should not be a problem in this group. We are working very hard to make sure that any of those biases and myths are taken away even amongst the larger clinicians, populace of pulmonology.
So let me flip it the other way. How many of you are comfortable using morphine for breathlessness? One. How many of you have easy access for breathlessness? I mean, for morphine. And third question is, do you have enough robust evidence to share it with your colleagues who are refusing to prescribe morphine for breathlessness? And a large chunk can be respiratory physicians or general physicians also. Would any of you like to answer that? In fact, why don't you do, Prakhar, Ganesh? You have access to morphine. Are you all comfortable to prescribe morphine? And do you have enough evidence to share it with them? I mean, we have to only teach them with papers and what robust evidence exists on using low dose opioids for breathlessness. Would you want to unmute and talk? Okay, Rajni, there are some more questions. Use morphine in pulmonary edema. Any exercise to teach ILD patients to maintain the disease?
So pulmonary rehab is a large part of the management of patients with chronic respiratory disease. And the goals of pulmonary rehab are will keep changing depending on the patient's symptom burden and where they are in their disease trajectory. Sometimes we are focused on improving function, so ability to walk and muscle strength, and other times the pulmonary rehab focus is on reducing symptoms. So pulmonary rehab and physiotherapy and exercises which can be taught and can be administered by the caregiver themselves also are a large part of breathlessness support services and the palliative care of patients with chronic respiratory disease.
Sangeeta is asking, I want to know about the uniform record keeping format of morphine dispensing. Sridevi, do you want to chip into that because you're the best and the veteran in that?
Yeah, I was just thinking, I was seeing the question. I wish I had access to the register photograph where I can show. Um, so there are certain forms, Dr. Sangeeta, which you have to fill in, and there is a format on the register. I can do one thing. Maybe I can send those pictures to you, to this group actually, through WhatsApp or email. Raju just remind me to send that from the opioid availability thing. So there are forms and everything is mentioned in that, which form to be maintained, which form to be given to the patient, and how to order. And again, record keeping, how to enter into the register and in what format, where to get signature by the RMP. So I'll send those documents and then we can take some questions once you go through it, and if you still have any doubts regarding that. Because I don't have
So
access to those pictures right now.
sorry,
That's
sir.
why.
So also there's this question about morphine and pulmonary edema. Please remember that the indication for morphine low dose is for any etiology of chronic breathlessness. So I'm going to be touching on that. So maybe there'll be more questions after that, or some of your questions might get answered during the talk, and including the talk by Tamshia, where she says we are using morphine only for cancer. Can we use it for other conditions like COPD? So with your permission, I will start the conversation about chronic breathlessness, and maybe we can then touch upon these answers. Is that okay, Rajani?
Dr. Rajam, can I
Yes.
just show that photo which Dr. Sridevi?
Yeah, sure.
Was this mentioned the thing which?
Yeah, this is just one, Dr. Sangeeta. This is the register. If you can zoom, Raju, is it possible? Yeah. So
No.
this is a register in which we maintain the records, like the date, the registration number of the patient, the name, and how many morphine you gave the patient. Suppose you have 2000 morphine with you tablets, you give 100 to this patient, and then you have to write 2000 minus 100. So now I have 1900 morphine. So you have to reduce that number you have issued from the total number you have. This you do every time that you issue morphine, and then will be countersigned by the registered medical practitioner. And we'll share this presentation if that helps, because in this presentation we have mentioned which all forms, which all records to be maintained, and who should use what. So that becomes a little easier for you. Thank you, Raj. Thank you.
So with that, we come to chronic breathlessness, where I hope that some of you will be able to, some of the questions that you asked will be answered. So how many of you can tell me what do you all understand by chronic breathlessness? Because it's a refresher course, I'm sure a lot of you would have heard this definition of chronic breathlessness. Is it possible for any of you to share it? I know Rajni is there for some more time, and Sridevi is also there to help me with the answer. So what, according to you, is chronic breathlessness? And then we can throw some light on it. Any of you? Is there something in the chat? Achha, Rajni sent something.
Not yet.
Anybody wants to unmute and tell us what is chronic breathlessness, or what do you think? And today, in the context of respiratory palliative care, what do you think? Because I think Rajani referred to as chronic pain syndrome, which I'm sure all of you are. So Prakar has written breathlessness affecting activities of daily life. Yes, in one sense, one partly. Excellent. Despite treatment, patient doesn't get a relief. Very good. What else? So the whole point here is we are having a conversation today on respiratory palliative care. So this is therefore a definition that has been defined by a Delphi group, where they said it is irrespective of the duration of how long the patient has been breathless. But when the breathlessness is present despite maximum medical treatment for the underlying condition, which could be COPD, it could be ILD, it could be pulmonary edema, it could be CCF, it could be neurodegenerative, any cause of breathlessness which results in the patient being continuously breathless at minimum exertion or at rest, uh, despite being on maximum medical treatment, and that affecting his activities of daily living, in the sense it affects his psychosocial, financial, functioning. So when it affects, so it's not just a physical component, it's a total component, like total pain, where the patient is physically, emotionally, mentally, psychologically, and socially affected. That is chronic breathlessness syndrome. So any advanced respiratory condition, any advanced cardiac, any advanced motor neuron, or for that matter, any advanced cancer, which is spread to the lung or not spread to the lung, because these patients do have a lot of cachexia and they have a lot of muscle loss, and therefore the respiratory function, muscles function is also lost. So if you identify any patient with advanced organ dysfunction or advanced cancer to be breathless, that is chronic chronic breathlessness, right? So I have got a case for you, and that it is important for me to share this case because now all of you are obviously looking at patients with a palliative hat also. So if you come across this gentleman who is 78, who's had a chronic COPD, he lives with his 75-year-old wife, both the children are away, worsening breathlessness, on long-term oxygen therapy with comorbidities of diabetes and ischemic heart disease, he comes to your clinic. What will your consult include? As a palliative care physician, I'm stopping sharing now so that you can all talk to me, our chat. What would your consult include, or what should your consult include? If it's a 78-year-old with worsening advanced COPD, worsening symptoms, on long-term oxygen therapy, along with the fact that he's got a 75-year-old wife who's his main caregiver, children are away, what will your consult include? Can anybody share this with us on the chat or unmute and talk? Yes. If this patient comes to your clinic, what would your approach be? Or what all will you include in your conversation? Yes.
Ma'am, how long the breathlessness has been?
Yes.
What are the aggravating and the relieving factors?
So somebody has written history and examination. In the light of today's information and the light of a palliative care session, I know as doctors, you will do onset, duration, progress, what worsens, what improves, what medications are you taking, etc. But in today's light of respiratory palliative care, what else will you ask? How will your consult be complete? What are the
Is there
questions
any-
you will ask?
Is
Yes?
there any possibility for them to have oxygen therapy at home? And is there anyone else who can really be the caregiver like around the clock
He's
at
already
home?
on oxygen, long-term oxygen treatment. That is already on. Yes, you talked about the caregiver. Yes, before
Caregiver.
that, can we ask about the patient itself? What else will you ask the patient? How do you know? So, for example, history taking is an art, right? History taking, we always ask, is your breathlessness better? Are you feeling better? It is important for us to decipher how bad is the patient's daily routine because of breathlessness? So how will you reframe that question? Another way of reframing that question is, what have you given up because of your breathlessness? What is it that you have stopped doing? And that is when you will come to know when the patient is not able to be independent, go to the toilet, self-care, open the door, pick up the phone, or play with his grandchildren or talk to his friends. So you realize patients with chronic breathlessness, the exercise that Rajni told you to do, they actually die a social death before a physical one, because they're isolated, they're bed bound, they're house bound, they're oxygen bound. Some people are NIV bound. So we need to understand the way the patient lives, because as doctors, you and me are trained to look at physical symptoms, and that is the tip of the iceberg. What is the consequence of that particular patient's life? What is he allowed to able to do? What is the quality of life is something you and me are not trained to think about, because we also feel we are inequipped or ill-equipped to deal with the answers. You say, oh God, if he's going to ask these questions, and it is going to be a headache for me. And that is where the integration of palliative care comes with the specialist. So it's important to frame your questions in such a manner that you get the maximum response. So first, thinking of the patient, his physical restrictions, his activities of daily life, his routine. So instead of saying, is your breathlessness better? What have you stopped doing or given up because of your breathlessness is going to answer the question. So the way you elicit answers is also dependent on how you ask these questions. Then, of course, his mental status. So I will come to that. What are the issues with breathlessness? What do you imagine you being bedbound, housebound? We were all stuck in the house during COVID. Even being physically fit, it was frustrating. So imagine how frustrated our patients who are unwell and stuck to the bed are. They're angry, they're irritated, they're frustrated. So it's important to explore their mental health. Are you scared? Are you anxious? What is going on in your mind? So physical, emotional, psychological, social, because his friends will also be his age. They will also have different chronic illnesses. They might not be able to come to see him. So a lot of issues go on to patients who are chronically breathless. And there are some very good answers coming. Sridevi, do you want to? So yeah, so economic support, yes. Children are away. So who's the main caregiver? Is the caregiver feeling supported? Does she know what to do in an emergency? What is troubling him? Yes, physically, emotionally, functional status of the patient's quality and caregiver perspective. So all this is important. So the reason I put up this is because all of us, when we are trained to become MBBS doctors, there's a typical history taking that we do, and we stick to that. We need to realize that our consult should change when we are, when we are wearing a palliative care hat. So with that, I go ahead. So please remember, whenever you ask any patient who suffers from any serious illness, please explore emotional issues, social issues, financial, and also address caregiver burden, because all this contributes that patient's daily life. Okay. So going ahead, this is what is chronic breathlessness syndrome. So despite maximum treatment, when there is a lot of hampering the physical limitations as well as psychosocial limitations. Okay. All of you are aware of the breathing, thinking, functioning model. So this actually beautifully describes any patient who is chronically breathless. So because his breathing is affected with the COPD or ILD or CCF, the main problem here is, of course, that there is increased work of breathing, accessory muscles of respiration are in action, and there is obviously inefficient breathing, which also results in the patient being constantly with high respiratory rate. Now, when the patient is so breathless, it is natural for him or her to be anxious. So there is an overdrive in the mind. He's anxious, he's scared, he's fearful, and therefore he gets more breathless. So it feeds into the breathlessness. And when you have a breathless patient who's also very anxious, the first thing he or she does is doesn't move from the bed, because this is the position that I'm comfortable, I'm not going to move. The more the patient becomes immobile, the more he becomes deconditioned. And when you lose the muscles, you become more breathless, because the diaphragm is also a skeletal muscle. And so the less and less you use, the accessory muscles, the upper limbs, the muscles, the quadriceps, the hamstring, they are going to degenerate. So the patient is caught in this vicious cycle of breathing, thinking, functioning model. And it is palliative care, which with its multidisciplinary approach actually helps to cut across all this. The pulmonologist can look after the breathing, the psychologist looks after the thinking, the physiotherapist looks after the deconditioning, and the palliative care physician is there to encourage the patient, give the necessary non-pharmacological and pharmacological interventions, and see to it that the patient is able to do his activities of daily living with less effort. See, none of us have a magical wand, and we do not have ways to cure COPD or ILD. But given the lung function, if the patient is able to lead his life in a comfortable way, if the patient is able to do, for example, go to the bathroom on his own, eat with his family, talk to his grandchildren, that also is a big effort for them. It is like us training for a marathon. These people need to train to do their activities of daily living. So this model explains the situation in which our patients are caught very badly, and it is only palliative care that can have a multidisciplinary approach and see to it that we alleviate symptoms. Okay. So typically somebody was asking about COPD and opioids. So if you see the stepwise treatment of COPD, you should ideally be starting the patients on his normal treatment, which is short-acting bronchodilators, the antimuscarinics, the long-acting bronchodilators, the oral theophylline, oxygen, and then slowly introduce pulmonary rehabilitation and low-dose opioids along with his treatment for COPD is the step which is the where patients are in advanced COPD, or what we call as gold stage 4 or 5. So yes, COPD in COPD patients who are chronically breathless in advanced conditions, you can and should evaluate for use of opioids. Okay, because as discussed by Rajani, there has been publications to show that when the patient's physical capacity decreases, the mental component also declines. So all our patients who are chronically breathless or in chronic pain or who have any serious illness will be affected mentally. And it is for us to explore and tap that. Okay. So this is again the COPD, the physical functioning. I will skip all this. This is what Rajani was trying to say, that all specialties need to integrate palliative care early so that the transition from curative to palliative is smooth, and the transition from life to death is also comfortable for the patient. And following death, the bereavement phase for the relatives is equally needs to become supportive, because these patients have been these caregivers have looked after patients for more than 3-4 years sometimes, and it can be a big void in their lives to lose these patients. So it's very important to realize that our patients with breathlessness have all these issues which you and me as palliative care physicians need to tap. The dependence on the family, the loss of role, social isolation, anger, frustration, anxiety, death, the fear of death. So in your consult to that 78-year-old man, you need to build a rapport and slowly be able to establish what actually is bothering him and what exactly support he requires, because palliative care is need-based. It is nothing to do with diagnosis or prognosis. Some people cope, some people don't cope. And we need to identify those who don't cope and help them overcome that. So this is the art of history taking that we need to change. Ask open-ended questions and ask questions which are going to give you the maximum answers. Yes, it will be uncomfortable for you and for the patient, but unless we ask, we will never know. Okay. So the other thing which is important is when do we integrate palliative care in respiratory medicine? Because most of the pulmonologists say it's too early, the patient will lose hope, and we are not able to actually, it's not right to talk of palliative care, because even today, palliative care is thought to be end of life and palliative care is thought to be for advanced cancers. That is no longer true. And we can really make a difference in the patient's difficult journey by integrating early. And I think both Rajani and me will vouch for that by just being there for the patient. So in order to make this easy, we have a surprise question, correct? And the surprise question is, if you have a patient sitting in front of you, in your own mind, you think, will this patient be alive in the next 1 year? And if the answer to that question is no, that is the time to integrate palliative care. So in COPD, there are the two articles, which is gold standard framework and the blue maple document, which tells you exact criteria of when to integrate palliative care in COPD patients. For example, in COPD patients and any elderly patients with repeated hospital admissions, the MRC grade 4 or 5, and a deteriorating lung function on long-term oxygen, along with a lot of comorbidities, these patients are going to be. So any two of the following, if the patient has, the probability of the patient reaching the next Diwali or Christmas is going to be rare. So we need to start talking about his beliefs, his desires, his understanding of the condition, the futility of aggressive treatment, and offer him what is in his best interest. Any questions?
No questions in the chat, but if someone wants to unmute and ask.
Madam, how do you answer the question patients themselves? Why am I being referred to palliative care now?
Say that again, please. I didn't understand.
The patient themselves sometimes ask, why am I being referred to palliative care?
Yeah.
Is
So
there
how
no
do you answer that?
Yes.
So, it's a very good question. So today, the colleagues with whom I work, they say that I am going to refer you to another member of my team so that it's not like somebody else totally. 1, 2, she will focus on the quality of your life, offer comfort and supportive care to improve the quality of your life. Because again, there is a big misnomer and a big debate about palliative care. Like I said, everybody says, oh God, am I going to die? Why are you sending me? I don't have cancer. But you need to, unless you start and see, it's very sad to say that I will refer you to another doctor because they feel that, oh, my doctor of 5 years is now sending me to somebody else. That also is a sense of abandonment. So the way now the colleagues introduce me is a member of my team who's also a pulmonologist, because I happen to be one, but who is going to improve and focus on your symptoms and your quality of life. Not all patients come, but when a patient has a dip, that's when he realizes the urgency to meet. And we've actually had a very good experience over the past 5 to 6 years, where almost 80% of our patients are satisfied with our treatment. They're happy that there is a doctor at the end who can actually say, now I'm feeling this. Can I go to Lonavala? Can I do a road trip? Can I take an air? Simple things. Because another thing about palliative care is it's not just doctors. There are nurses, there are social workers, there are volunteers, there are physiotherapists. So, even the patient feels intimidated to ask you and me stupid questions like, should I go to Lonavala by car or by train? Maybe doctors say, why are you asking me such stupid questions? But the point is, it is a logistical issue, right? Even you and me, if you have a sick parent, we will also have 20 questions to ask our doctors. So similarly, it is easier for patients to ask non-medicos, and therefore you introduce them as somebody who focuses on the quality of your life and will focus on your symptoms and any other issues that you have, so that you can lead a better life. Because we need to realize that when you have an illness like COPD, IHD, CCF, ILD, CKD, we are not able to cure these patients, right? We only control these patients. So actually, we are already giving them palliative care. But what happens is we do not prepare them for the end of life. These people unnecessarily do undergo a lot of aggressive, futile treatments in the ICU. They get intubated, ventilator, central line, arterial line, dialysis. When we know the outcome, see, you and me know the trajectory of a advanced lung disease. So it is your and my onus to start talking to these patients about it. At least we need to try. Not everybody is going to say, yes, doctor, let's talk about my death. Nobody's going to do that. But we don't even try. Point is, there is a sensitive way and a very effective way to communicate these difficult issues. We need to learn that, we need to practice that, and we need to try. If you try talking to 10, 8 will listen, 5 will understand, 2 will act. But at least the 2 will act. If we don't talk at all, there is no question only of anybody even listening to you about palliative care. Isn't it?
Ma'am. And sometimes they think that there is no further treatment for them. That's why they are being referred to palliative care.
So that's another thing which is again been made very famous by Bollywood. Abhi main kuch nahi kar sakta hu, which is a rubbish thing to say as a doctor, because there is a lot to do to comfort the patient. Yes, we might not be able to cure, but there are enough to do to care for the patient. Patient is not just physical symptoms, right? He has so many other things. He has to get his daughter married, he has to send his son to college, he has to see that his wife's finances are good. There's so many things in a patient's life, especially when you have any chronic illness, you know that you're not going to get cured. There's so many aspects in life, not just physical. And I agree that it is not all a doctor's purview to sit and look at his bank statements, this, that, but at least address those issues, acknowledge those distress, and refer him to the correct people, maybe the the social worker, or maybe you can refer him to a financial planner, so that he knows what he's doing and he is not caught unawares, and his family is not in trouble after he goes, isn't it? So we need to address those issues. See, for example, I have patients of motor neuron disease. Okay, we know that ALS has no cure. We know that slowly they will fade. They cannot sign. It is important for us to say, please keep your finances in order. Please, appoint nominees. Please give your signatures in all the banks. Take a letter from the neurologist saying you might not be able to sign anymore. See, these things they will not know. You and me know how the disease progresses. And when you are diagnosed with an illness, you're so focused on getting better that all these other things are forgotten. And patients are in a big soup because money doesn't come, no nominees are there, because a lot of patients rapidly deteriorate. Then there is nothing done. The house is not in order. The banks are not in order. So these are the things that you and me should be able to help with the patient, because of the fact that we know how the disease progresses. Isn't it? So that is also palliative care. Palliative care is not just end of life. So many aspects of in the disease trajectory of a chronic illness will need a doctor who is removed from the situation and says, you can have this problem, you can have that problem. Do you have this problem? Identify, acknowledge, and try to help the patient. You and me can only try to help, but at least we need to try. Okay. So when you have a patient of breathlessness, what are the things you will tell the patient and the caregivers to do? And that is very important, because very often what we end up doing is, 1 minute. Yeah. So very often what we end up doing, we end up doing what we are constantly asked to do, right? Always. When you have a breathless patient, the first thing your ward nurse also will do is put in an oxygen. But there are a whole lot of non-pharmacological things you can do. First of all, the position of the patient, loosening the clothes, sitting next to the window, asking the patient to be taught by the physiotherapist how to do deep breathing exercises, massaging the patient, tell him to do pursed lip breathing. And a handheld battery operated fan works magically for patients who are very breathless, because it calms there are studies done to show that the MRI patterns change in the breathing centers and the patient becomes much more calm. And you must have seen very often patients saying, please put the fan on my face, please, because they feel a great sense of relief. So you must focus on non-pharmacological treatments of breathlessness, which is very important. And if you teach this to your caregivers, they also feel a sense of doing seva, of rubbing the back, pursed lip, relaxed breathing, handheld fan. So it's very important to focus on the non-pharmacological treatment for chronic breathlessness. Any doubts or any thoughts? Have you all tried to use any of this?
Anyone in this group has experience in using any of these techniques in your practice?
No? Is it difficult,
No,
you think, to teach the caregivers?
Dr. Sangeeta, so that's a yes that you're doing this in your practice, I guess. There is one yes in the chat. Yeah, positioning, relaxation. Yes, there are a few yes for the non-pharmacological techniques,
So
Dr.
is it
Rajan.
difficult or they're doing it? The yes is for the doing it.
Yes, they're
Okay,
doing it.
great. Okay, so fine. So that is great. Now, the other important thing that I would really like to bring your, we are doing it. Excellent. So this is perfect. What are your thoughts about use of oxygen in patients who are chronically breathless? Oxygen. Do you put oxygen on all patients who are breathless? What is the science behind it?
In ILD, definitely most of the patients will be in need of oxygen when the disease progresses.
What is your criteria, ma'am? Is it the diagnosis or is there some other criteria for use of oxygen?
Making the patient to be comfortable.
Is that a criteria?
Also,
To start oxygen, I'm saying.
Look for saturation.
Yes. After COVID, everybody knows about that. So saturation is the most important. What is the acceptable saturation where you needn't start oxygen even in ILD patients? SpO2, correct. SpO2 less than 88 to 92. 88 to 92 is the safe zone. We do not want above 92 in a patient with advanced lung disease. We do not want below 88 to 87 in an advanced lung disease because the oxygen saturation loop drastically falls once the saturation is below 88. So if you have a patient who is very breathless, you have checked the saturation and it is 90 and you try all the non-pharmacological, put the fan, do everything, automatically the use of oxygen is not needed. What happens if you give oxygen when it is not needed?
oxygen toxicity.
No, it is nascent free radical damage to the lungs. So there is a saying in Sanskrit, na, Adhigamanal Amritam Visham. If anything becomes excess, even Amrit becomes vish, even the nectar becomes poison. So oxygen is pranavayu, but when you give it unnecessary, it also causes oxygen free radical damage to the lung. Secondly, in COPD, when you give a lot of oxygen, it can actually lead to type 2 respiratory failure, where the carbon dioxide starts building up because the brain says there's so much oxygen, I don't need to breathe. Let the carbon dioxide go. So patient actually ends up becoming drowsy. So please use oxygen judiciously. Please do not give oxygen to all breathless patients. Please be selective. Try non-pharmacological. Try or give the oxygen only if the saturation is low. Okay. And then comes the beauty of morphine. Now, morphine, you must remember, is such a safe drug in all these 6 years. And I'm sure Sri Devi in many more years has used it and has not resulted in respiratory depression and death. Sorry, there's one more comment from Prakhar. Sometimes oxygen acts as placebo. Well, the patient gets constantly used to using oxygen. That's why it makes him relieved. But if you explain to him that actually taking oxygen without indication, it actually will convince the patient that it is okay to not use the oxygen. So yes, it is a process, but problem is in the wards, in the house, anytime you see a breathless patient, the first reaction we all have is to put oxygen nasal cannula. So it can act as a placebo. So sometimes you can even just put the patient with a nasal cannula, try all the non-pharmacological, and then convince the patient and not give the oxygen or give the oxygen. But please use oxygen judiciously, especially after the second wave of COVID. We've all realized how difficult it is to get oxygen, and people who really needed the oxygen didn't get it, right? So the dose, yes. So are you talking of morphine? So yes, so we are coming to the morphine. So first of all, morphine is safe. It doesn't cause a depression in the respiratory center or death. it also, you need to realize that you need to start in very, very low doses. So the mantra for oxygen, for any medication, the mantra for any medication is start low, go slow. So you must remember, we start with 2.5 milligram immediate release because that is what is available in Bombay. So we start 2.5 immediate release, 12 hourly, and then we give the patient laxatives and perinorm. Laxatives for the so that the patient doesn't get constipated, and perinorm is to prevent nausea, which can be given for the first 2-3 days and then omitted. So we start with 2.5 milligrams twice a day and slowly increase to thrice and 4 times a day. And we never rarely require more than 20 milligrams in 24 hours. So unlike pain, where there is no ceiling dose for morphine, in breathlessness, if your patient is not improving, then there is something else that is grossly wrong, or the morphine is not acting well on the patient. So it's not that everybody will benefit, but yes, a large number of patients benefit with, and it really greatly increases their quality of life. So what I can share with you is people who come on the wheelchair in the first visit and consult after 2 to 3 weeks of morphine can actually walk from the parking lot to the clinic. So it improves their quality of life in the sense they can do activities of daily living with less effort. They can walk to the toilet. They can self-care. They can be a little more independent. It's not that we have done anything to their underlying lung condition. It is just reducing the sensation of breathlessness, the work of breathing. So respiratory rate drops from 35 to 20, and the patient is able to take deeper breaths, improves the tidal volume, improves the saturation, and the patient feels less breathless. That's all that morphine does, because it's a centrally acting medication. But you must evaluate your patient correctly. You must explain to the patient about morphine and how safely he has to store and use it. And he has to cut the tablets and keep, because the available tablet and dose in Bombay is 10 milligrams, and he has to cut it into 1/4 and take 2.5 twice a day. Then after 3-4 days, and after evaluation, 3 times a day, and then 4 times a day. Maximum dose required is 20, and patients live after their interaction and evaluation with me for at least close to 8 to 9 months on morphine, well able to do their activities of daily living. And then, so that it is important to realize that it is not only at end of life that we use morphine, it actually improves the quality of life of the patient with advanced COPD, ILD, CCF, MND, so that these patients are able to live well for the amount of time they live. Any questions?
Is it in any form, oral, parenteral?
So in all our patients, when they are conscious and walking, talking, we do oral. In the West, most of them do sustained release, but I do only immediate release because that's what is available. So usually we use oral. We very rarely prescribe patches. I know patches are much more fashionable and much more easily prescribed, but in a country like India, it is first of all very expensive. 2, please remember that we are a tropical country, so the absorption between sweat, not everybody can live in air conditioning. 3rd thing, when you put a patch, the release of morphine starts only after 12 hours. We do not know the amount of circulating morphine in the system. So if on the patch the patient is breathless, you don't know how much morphine to give or not to give to make the patient comfortable. So there is no control. Best is to tell the patient to start 12 hourly and then tell him SOS if you need. You see how much SOS he's taken and then adjust into your full day dose of 4 hourly, 6 hourly, or 8 hourly. So best is oral. There is better control. When patients are not able to swallow, I'm going to come to that next. We use subcutaneous infusion of morphine. So any role of saturation? Sorry, yeah. Any role of saturation in starting morphine? So please remember that morphine is given in patients who are chronically breathless. These are patients who are obviously very breathless because of the fact that their disease is advanced and they do have already dependent on oxygen. They are already on long-term oxygen therapy. So they're already there using oxygen because they are very advanced stage 4, 5 COPD classification. So they're already on LTOT. So there's nothing about morphine and saturation, except that we have noticed morphine improves oxygen saturation and actually reduces the amount of oxygen that the patient requires. And what is the criteria to stop morphine? Well, first is if the patient is intolerant, if there is no action, and if the patient hates the constipation. Otherwise, the patient takes morphine till end of life. There shouldn't be any reason to stop morphine. Rakesh, now dexamethasone is a steroid, right? Dexamethasone, the role is only in acute exacerbation or when there is an active inflammation in ILD. There is no role as a medication for chronic breathlessness. In acute settings, yes, dexamethasone will work. So in that sense, if a patient is acutely breathless, then there's no role of morphine. We are talking of chronic breathlessness syndrome, where if the patient is acute on chronic breathlessness, yes, steroids and morphine can overlap. Or if you're talking of a palliative care emergency, like a supravena caval obstruction, spinal cord compression, then you can give a steroid along with morphine. But in an acute setting, there is no role of morphine. We are talking of morphine when you have exhausted all other modalities of breathlessness to be controlled and you use morphine. Am I clear? Yes, no, maybe. Yeah, thank you. Yeah. So please remember, morphine is not your first line prescription. You have used everything. You have tried rehab, oxygen, counseling, everything, and patient still continues to be breathless. That's when you start using slightly low dose of morphine. Okay. So now coming to the other routes of morphine, that is what we call as treatment of terminal breathlessness. So any of our patients, not just respiratory, cardiac, MND, cancer, the ones who are breathless towards end of life, that is what we want to treat is the terminal breathlessness, like how patients are like a fish out of water. When we know we do not have a cure, how do we comfort the patient? So when you aggressively treat to comfort the patient, that is the time when we actually start doing this, which is a subcutaneous infusion over 24 hours of a combination of morphine and midazolam. When we are very sure that's what is communicated and documented with the patient and the caregivers, this is in order to make the patient comfortable, sedate the patient so that he transitions in peace. This is also called palliative sedation or aggressive control of distressing symptoms towards end of life, which is what is important is the patient be unaware of his distressing symptoms and then keep him comfortable. So this is palliative sedation. The intent is comfort. The side effect is obviously death. Therefore, communication and documentation has to be impeccable. Please remember that you're only wanting to keep the patient comfortable. For the caregivers also, it is less distressing. As you all know, the manner in which a loved one dies is etched in the memory of those who live on. So it's our onus when the patient is reaching the recognize active dying, recognize the futility of aggressive treatment, keep the patient comfortable. So this is what we often use in patients with interstitial lung or advanced COPD. Give a combination of midazolam and morphine, 10 milligrams and 5 milligrams of midazolam in 24 hours. So very small dose, very baby dose. Only reason to give is to achieve comfort, not to end life. So please remember, there's a clear distinction between palliative care and we usually dilute it in a saline, or you can do it for water for injection and we give it over 24 hours. Yes, we do it in home care settings wherein we rope in the family physician. We take the necessary signature and the document. There is a nurse in the patient's house and the subcut is prepared and it is given through. We now get syringe drivers available in the chemist. We give it through syringe drivers and we do it in home care. And very often I just get a message, thank you for all your help. My father, mother, brother has passed away peacefully. We do all this when terminal patient with breathless not willing. So you can only try. Tamshia, we cannot force people. If they're not willing, see, very often in the ICU also they give fentanyl. They do give fentanyl for patients and they do give sedation before intubating a patient. So if they're not willing for sedation, then you can obviously try a fentanyl patch or a morphine patch and give SOS midazolam. But it is extremely distressing to see a terminal patient breathless. For the patient also, for the caregivers, for the doctors, for the nurses, it is a horrible feeling. So you must try, and that's why these discussions cannot happen at the bedside when the patient is dying. That's why early integration has to happen when the patient is, still able to discuss, decide, and therefore we prepare. All this is discussed and decided that the patient is not coming to hospital or coming to the ward. The family physician knows what to do, where to buy the morphine, how to set it up. All this is discussed. It is not discussed at the end when the patient is serious. Can we use morphine for those who are on bronchodilator? Yeah, of course. So this mechanism of action is completely different. Morphine is centrally acting. Morphine reduces the respiratory center. It reduces the work of breathing and also makes the patient less anxious. There's no connection between saturation and breathlessness. Please remember, all breathless patients are not hypoxemic. It is also to do with and in patients with COPD and ILD, they're already on oxygen. So it's irrespective of that. It is a sensation, the distressing symptom that they face of breathlessness. Okay. So these symptoms also, I think Rajani had talked to you. I just wanted to share 1 minute.
I think there was a question on how much saline to be used to dilute morphine. Man, I feel it entirely depends on what rate and what dose you are giving and for how long. So, right, Rajam, if you're giving at
So
home or
24
even in
hours,
the
we usually can give, we usually do give in about, in the syringe pump, you can only put 100 ml, right?
Yes, yes.
So
So
we
it
put
depends
100
on
ml.
what device, yeah.
Correct. And then we set up the drip rate in such a way that the patient is comfortable.
So dilution is not really important, like the concentration is not important. The dose, how much to
Drip
be
rate.
given is that's only thing that you need to take care of.
Yeah, correct. So I also had prepared to share with you about interstitial lung and needs of patients with palliative care, but I'm not sure there is time. So I'm happy to take questions, and as and when there's anything on interstitial lung, I'm happy to answer you. But the whole purpose of this thing was to recognize the fact that palliative care is need-based. It's irrespective of diagnosis and prognosis. It should be involved and integrated in any serious illness. First, we used to say chronic illness, but COVID changed that also. So COVID changed that even in an acute illness, if there was palliative care, there would have been so much support for doctors, nurses, patients, caregivers, etc. Most important thing is when you feel that a patient is not coping, you really need to get a psychologist or a counselor on board. You need to start asking history taking differently so that you can get this out of the patient. And some patients need more time. Those patients you should slot towards the end of your OPD because we don't have time to handhold everybody. And if you master morphine in chronic breathlessness, a lot of burden is off your chest and that of your patients and their relatives. So there's another question from Viji. Can we use morphine for those who are on bronchodilators? Yes, that I've answered. How much do we dilute with morphine? So, we use 100 ml saline, 10 milligram morphine, 5 milligram midazolam, and we started in the syringe pump over 24 hours. So we give very small drip rates. And if the patient is not settled, we slowly increase the drip rate by 10 to 20%.
I have just answered the subcutaneous sites. So any sites that you recommend for insulin injection, all those sites you can use. But the very common ones we use are forearms and thighs and abdomen and sometimes near the clavicle. So any site that we recommend for subcutaneous injection, those sites can be used. There is a question on morphine patches. I am not sure whether I have
So
not
I try
seen
to
or
ask
used.
I try to answer that. See, fentanyl and buprenorphine patches have become very popular. These patches are from the range of 5, 10, 25 and 50. The danger of using these patches is, one, expensive, not everybody can afford. You have to change every 3 days. Absorption is erratic in a hot country like India. Then you don't have a control. So if the patient is on a patch and breathless, you don't know how much to give. So it's best to start with oral if the patient can swallow. Sangeeta, thank you for that. Morphine in chronic non-productive cough. So any persistent cough, very good question, and thank you for asking. Again, we start with non-pharmacological. So we have to find out where the cough is, because cough is not only from the chest. It can be lungs, it can be heart, it can be gastric, it can be ENT, it can be upper respiratory, it can be drug related, it can also be psychogenic. So you need to get to the bottom of this cough. So you need to evaluate history taking, X-ray, you need to find out whether it's related to food. So all that, once you evaluate and once you know the reason of the cough, and if it is not coming under control, you try the non-pharmacological. So hot water, ginger, tulsi, all those things you try. Then you can try codeine syrup. Then you can try morphine, low dose, like you do in chronic breathlessness. And now there is research to show that gabapentin, first use as 100 milligrams in the night and maximum is 300 to 600 milligrams in the day, helps refractory persistent cough. There are many evidence in literature saying that gabapentin works very well after, of course, once you have tried everything. Please remember that you need to exhaust all your options before you try these options.
From the chats, I understand the session was very clear to everyone, Rajam, although there were a lot of information from today's session. I'm glad that people found it useful.
And I'm happy, I'm available on email. So any questions, any queries, please feel free, especially to bust the myth on morphine. And I really want all you people to be confident in using morphine. So if there's a case you would like to discuss, send it across. We can have a discussion and then we can see if this is ideal and what all you need to check before you start morphine and after you start morphine.
Thank you so much, Rajam. Thank you so much, all the participants. As Rajam mentioned, if you have any questions or anything that you feel that you are stuck when you manage patients with breathlessness, please write to us or Rajam, or just mention it in this WhatsApp group that we have. We can arrange a teleconsult, something like that, or a session, or we can get your opinions as email, so we can work on that. Thank you so much, everyone, for your wonderful comments, and that's a real encouragement for all of us. Thank you, Rajam, and I'll
Thank
convey my
you.
thanks to Rajni also. See you all with another topic in the coming days. Thank you so much, everyone, and have a good weekend.